effect of racial disparities across such areas as not having enough food, not being able to pay your mortgage on time, not having health insurance, and feeling depressed or hopeless. Again, we need to pay attention to the disparities that exist between different groups related to race. We will now highlight the Children's Report Card from 2020. Next slide. C, where we earned a C+. Thank you. Education, where we earned an F. Economic well-being, where we earned a D+.
Oh, you learned an F. You earned an F.
And one we'll delve deeper in today, health, where we earned a D.
How did you earn a D?
For health outcomes, you see that access to health care was rated as an F and stayed the same as in previous years at the bottom. Prenatal and infant health went down and was rated as a D.
Look, mine is F.
Immunizations went up to a C-. Childhood obesity was a C- as this grade dropped. Dental health was an F-, decreased. Mental health was a C and decreased. Sexual health increased to a C. Next slide, please.
I don't know how they
In the state of Nevada, the rate of uninsured children was 8% versus 6% in the United States. And we're rated 45th in the country. Next slide. However, due to COVID-19, numbers have doubled. And 8 million Americans lost employer-sponsored health insurance, with persons of color being disproportionately impacted. Again, we're in this together. Some of the data is startling, but there is a path forward that you will hear about relating to early investments, as well as the prenatal to 3 policy roadmap, an opportunity to change the trajectory for our Nevada children through policy. I will now turn the time over to my colleague, Janelle Matz, who is the Strong Start Prenatal to 3 initiative.
Thank you, Annette. And thank you all for all the presenters that have given such great information today. Hopefully this will kind of bring it all around full circle. So here in Nevada, I'm sure you've heard the term Strong Start in many different entities. Strong Start was coined as a campaign for community outreach that's aimed at mobilizing parents, educators, advocates, community, and business leaders to make quality early childhood experiences a priority in the state. Children's Advocacy Alliance is the backbone organization that supports the Strong Start Coalition. The Prenatal to 3 initiative is an initiative that is supported by the Pritzker Children's Foundation. So that is something that we have worked diligently together with a plethora of community partners and business leaders to really move this initiative forward. The coalition is broken down by the implementation of 3 work groups to support the policy and resources that produce the best outcomes for young children and families. So those 3 work groups include the Strong Start Prenatal to 3 Maternal and Child Health Work Group, the Community Health Workers and Home Visiting Work Group, as well as the Early Learning Child Care Work Group, and some of which are on this call today. So we are excited to be able to speak to this initiative. Some of our goals in the Strong Start Coalition include having an additional 2,215 infants and toddlers that fall below 200% federal poverty level to utilize well child services under the 12-month continuous eligibility of Medicaid. So this is something that has come up as a reoccurring initiative that we want to support, is that 12-month continuous eligibility of Medicaid. We also hope to add an additional 8,500 pregnant people below the 200% federal poverty level on Medicaid that receive and utilize postpartum care services through Medicaid expansion. So again, looking at the 12-month continuous eligibility for those parents. And then in addition, we hope to add at least 450 infants and toddlers below the federal poverty level, 200%, having more access to quality childcare through the establishment of 450 contracted childcare subsidy slots of 3, 4, and 5-star centers, meaning that they are of high quality childcare providers. So again, we talked about how childcare is giving us that holistic approach to health of not just the child, but of the family, to buffer some of those disparities that we see in those adverse early childhood experiences. Okay, so if you have the luxury of participating in our Winter Policy Summit, we have the opportunity to have Dr. Osborne present on the prenatal to 3 policy impact roadmap that we have been heavily utilizing as a research-based model to discuss some of those policy goals that have the best outcomes for our children and families. And so I won't go through all 8, but we have highlighted 3 of those policy goals that we would like to continue to hone in on as we move forward. So 3 of the outcomes that we have really pulled out as things that we are truly highlighting here today is access. Again, families having access to necessary services like we talked about today through community health work, through healthcare services. Also reduce administrative burden. I know that there have been some movement with the Medicaid eligibility requirements to recertify. Identification of needs and connection to services, again, through our community health workers and home visitors. Parents' ability to work. I know we talked about this a lot during the pandemic when we were heavily into it about families needing to return back to work. But that also entails our child care providers being sustainable and being able to have the resources that they need to continue to keep the doors of our child care providers open, and parents being able to find sustainable work as they have family-friendly work environments that allow them to take that 6-month leave when children are born. So again, another opportunity for children to bond with their parents through that 6-week paid leave. That's something we are definitely interested in, and just being able to support our families, not both in the work environment, but also in the opportunity to return to work with that connection to childcare. And again, having equitable health and birth opportunities, so connecting families to services like we talked about today that produce the best outcomes for health. And again, just to highlight a few points for the policy roadmap, again, looking at where we rank in relation to other states. And although this data is not favorable, I think it's important that we highlight that there are specific areas here that we have moved forward in. However, we still have a ways to go. Looking at the percentage of low-income women that are uninsured, falling at the 27.6%, and ranking 40 amongst other states. Also looking at eligible families with children under 18 not receiving SNAP. So again, we look at those ones who are maybe eligible but not yet receiving services. And so our big mission is to really increase that utilization of services that we know is so important to our children and families. All right, so policy opportunities. We work really hard with our partners to determine what policies really impact children and families, and not just research-based, but really honing in on those community-based organizations, our state partners, to really refine our policy priorities. And so at this point, we are really highlighting equity in all policies. We talked about equity numerous times today, but we want to really highlight the importance of equity in all policies, that all families have access to vital services and resources, including home visiting, infant and early childhood mental health services as such. And then as well as parents' ability to work, including ensuring a sustainable child care workforce with livable wages. And lastly, ensuring healthcare access for children and families, including 12-month continuous eligibility coverage for children as well as pregnant people. All right, any questions?
Thank you so much for the presentation today. Are there any questions from the committee on these presentations or this presentation? I am not seeing any. Thank you so much for the information and for being here today. We really appreciate you and your time. And thank you again for your slides on the kind of your policy summary. We appreciate that, and we'll be looking at those issues. All right, we're going to go ahead and close this agenda item and move on to our next agenda item, item 14, early intervention services for children birth to 3 years of age from the perception of a provider. We have invited Foundation for Positively Kids to present today on this topic. We also have Rob Burns, who is the president of the Early Intervention Community Provider Association, available for questions after the presentation. We have folks, I can't tell if they're in the Grant Sawyer building or online, but please go ahead and introduce yourself and proceed when you're ready.
Good afternoon, Madam Chair and members of the committee. My name is Paula Hammock. I'm the Chief Strategy Officer for the Foundation for Positively Kids. My colleagues at the table with me today are Jennifer Lagana, Vice President for Early Intervention Services for Foundation for Positively Kids, and Rob Burns, President of the Early Intervention Community Provider Association. We do have a PowerPoint. I'm going to try to get it up. It looks like I need to have a password to get in, so maybe I can get some technical assistance.
Do we have IT in Grant Sawyer who can come and assist? Oh, perfect. It looks like someone's down there. Thank you so much.
Great, thank you. Again, for the record, Paula Hammock, Chief Strategy Officer for the Foundation for Positively Kids. Let's see, there we go. So we'll just give you a brief overview of the Foundation for Positively Kids. We are a local nonprofit located in Clark County. We were established in December of 1999 by our Chief Executive Officer, Fred Schultz. We provide several services to children to include early intervention services for children that are 0 to 3 years of age. We also provide 2 pediatric clinics here in Clark County. One actually is on the Child Haven campus.
I'm
and
sorry,
also
I
at
don't
the-
mean to interrupt, but we are not seeing your presentation in Carson City. I don't know if that is a broad.
Thank you, Chair. This is Kim from Broadcast. We are working on that one, please.
Perfect. We can see it now.
Thank you. Again, for the record, Paula Hammock with Foundation for Positively Kids. We also provide 2 pediatric clinics, as I said earlier. We also provide behavioral health services for youth 0 to 17 years of age. We also provide a social skills program for children 0 to 5 that may or are on the autism spectrum. We are currently working on becoming credentialed as an ABA program through Nevada Medicaid. And we also are in the process of becoming accredited as a home health program with ACHC. Some statistical information, and I won't go through all of it because it's pretty easy to read, I believe. But we have been a community provider of early intervention since 2009. We are currently servicing, as the writing of this PowerPoint, we were at 220. Today, we are at 225 children with 60 awaiting evaluation. Based on the children we serve, the most common service they need is speech. You can see that we average about 250 visits a month for speech therapy. PK Positively Kids has 3 full-time speech therapists and 1 part-time speech therapist. We also have 1 full-time occupational therapist and 1 part-time physical therapist. And then we have developmental specialists, and they provide on average about 300 visits a month for special instruction. I always like to start with the challenges and then we can end on a positive note. I think that's always best. But some of the challenges that we have in early intervention, which I'm sure is not new information to you all, is that the current computer system that is utilized by EI is outdated and not user-friendly. It is a case management system that does not incorporate billing processes, thus requires the same information to be entered into 2 different systems, making for duplicative work. Additionally, it doesn't have the capability to run reports that would assist in helping providers to track performance and outcomes. Since the pandemic, it has become increasingly difficult and to hire qualified staff that are willing to return to a home-based setting, which is not just something that PK is experiencing. I think that's overall. This is a larger issue as we are now being forced to compete with other corporate employers who are seeking similar qualified applicants and have the financial means to offer bonuses or have higher hourly rates. And that's, for example, like our speech pathologists, they are in high demand, as well as our occupational therapists and physical therapists. This also creates an issue with staff retention since employees are often seeking higher hourly rates. Specific to the bullet point that states return of referrals generated from PK clinic, I wanted to be clear is what we mean by that is that since Positively Kids has 2 pediatric clinics, sometimes children seen there are referred for EI services. That referral is sent to the state for assignment, and there's no clear mechanism to ensure continuity of care for PK, as we may not be the provider assigned to the family for early intervention services, possibly due to parent choice, of course, or because the case is randomly assigned to another early intervention community provider. We have very limited audiology services here in the state of Nevada, specifically to the county. The services for audiology is limited to only 1 provider and at 1 location.
That's
As
crazy.
stated earlier, early intervention services are provided to children between 0 to 3 years of age. And once they are 3, they are transitioned over to providers that service the age range of 3 to 5. Clark County School District is primarily the primary one that services those youth. We've heard that a lot of times children fall through the cracks, though that is anecdotal information. We don't have any way to track it because we're not the service provider. Something maybe to consider in the future is if EI was extended to 5 years, we may be able to meet, if EI was extended to 5, children's needs may be met or met before becoming school age. Again, you heard presentation about brain development, and those 0 to 5 years are critical. And so for kids to be dropped off at the age of 3 to another transition that may or may not be able to service them, it would behoove us to consider maybe moving to a 0 to 5 for early intervention services. Some of the successes, because we offer several types of services at Positively Kids, we are able to provide a continuum of care for a number of children we serve, especially those that are medically fragile or developmentally challenged. We have developed our own internal EI audit process, thanks to Ms. Lagana. And we are also an active member of what we call Positively Kids Quality Assurance Program Improvement Committee, which we are always looking to improve our processes. During the pandemic, one of the positives that did come out of that was that as we were providing telehealth services, it assisted our staff in strengthening their parenting coaching skills because it was having to be done through telehealth. And so we were not necessarily in the home. So really coaching up our parents to provide the service. PK continues to maintain a strong relationship with the state EI representatives, and we are committed to collaborating with the state and community partners to ensure that the children we serve are getting the best care possible. We are hopeful that over the next few years, we will be able to expand services we can provide to the children we serve. Going forward, hopefully in the rounds of maybe, we're hoping to launch a pediatric skilled nursing facility, and we are considering looking into providing medical daycare for these kids that are medically fragile. That concludes my presentation, and so we are eager to take questions if warranted. Thank you.
Thank you so much. And I appreciate you bringing your challenges and then ending on a success note. We always like to celebrate our successes in this state, but our job at the legislature is really to take on those challenges and find solutions and help enable our partners both at the state and in our private sector on ensuring that we're providing services where they need to be provided. So I appreciate, again, your challenges slide, especially so we can start to work on some of those solutions. Are there any questions from the committee on this one? I believe Ms. Gorlow, Assemblywoman Gorlow has a question. Please go ahead.
Thank you, Madam Chair. And just for transparency, I actually work at Positively Kids. However, I do not work directly with the early intervention program. But I wanted to talk a little bit about the children that are being seen, what kind of delays that you're seeing, and also the children that are awaiting evaluation. So could you explain a little bit more about how a child qualifies for early intervention and then the wait list that's currently that we're all experiencing?
They
Thank you.
automatically qualify for early intervention. Are
Thank you,
gonna say?
Assemblywoman Gorlow. Jennifer Lacana for the record. Currently, children qualify for early intervention services under 4 different categories. They would have to exhibit a 50% delay in one area of development, a 25% in two or more areas of development.
Yeah, how are they assessing these?
They would
children?
have to come in with a diagnosed medical condition, which falls under the category of auto eligible. Or we also have the category of informed clinical opinion. So there are times when children don't
then there's
necessarily
just
meet
health-
the other 3
There's
criteria,
health
but the
disabilities.
team really feels like this child would benefit from the services,
Mhm.
or that the family really would benefit
Like
from our
epilepsy.
support.
And a medical condition.
Most of the children that we
Asthma.
see come in with developmental delays,
Mhm.
and that can be in any of the 5 areas of development. We assess cognitive, adaptive, self-help,
And what happens when people
communication, and
disagree with
physical
you?
domains. We get our referrals primarily from pediatricians' offices,
That's
but
right.
we do occasionally get calls directly from parents who have noticed that maybe their children aren't doing the same things that other children their age are
The
doing.
CDC provides that information. Let's just share
The
it.
referral process is that all the referrals go through the single point of contact, which is NEIS. And parents do have the right to choose which program they want. But if a parent does not have a preference, then they are assigned to the next available program in the rotation.
Thank you very much.
Thank you, Assemblywoman. I just wanted to ask Mr. Burns, did you have anything you'd like to add from the perspective of the Provider Association?
Yes, as you
on
represent.
this topic area?
Hello.
Thank you, Madam Chair and members of the subcommittee. It's a pleasure to be here with you guys today, and it's good to be back in public view out of the House and seeing each other do what we can to kind of make this situation better for the children and their families. I'd simply echo the presentation slide, I believe, number 4, in terms of the trade associations. The trade association represents all the community providers with the exception of one, both in the North and the South here in the state of Nevada. And I think that there are 2 critical points here brought out in this slide in particular that we could certainly benefit from the state's help. And it's the critical staff shortages in terms of staff hiring and retention is going to be a huge one. As my colleagues presented earlier, there are other entities in the healthcare system that can offer reimbursement rates or payment rates or salaries that in the early intervention program we just aren't able to do. And then I think that the staff retention in our side and our programs are then compromised. And then lastly, I'd add then that have to make sure that we are adequately funded so that we can continue to service the children, because after COVID, it's our opinion that our child find efforts will increase and we'll see more of a need and a greater need as we move forward in post-COVID years. So I appreciate the opportunity to address this body, and thank you.
Thank you so much. Thank you for being here today. Appreciate the perspective. Are there any other questions from the committee from the provider perspective presentation? Well, thank you all for being here. We really appreciate your presentation and time in our committee. And we will go ahead and close that agenda item and move on to our next agenda item, item 15. This is the Early Intervention Services System in Nevada, assisting in the children's development between birth and 3 years of age. We have some folks up here in Northern Nevada. Do you have colleagues in Las Vegas who are also?
Early intervention.
Ricky Rob, for the record, we have them remotely, and there's actually 5 of us, so that's why we're here. And
Great.
Nikki is here to support
have
us in
them
our
remotely.
presentation today.
All right, I see some folks popping up on the Zoom. I'm going to go ahead and let you take the lead on who's presenting, and go ahead and introduce yourselves and begin when you're ready.
Great, thank you. Good afternoon, Madam Chair and members of the committee. For the record, my name is Ricky Robb. I'm the Deputy Administrator for Children's
Deputy
Services with
Administrator.
Aging and Disability Services. And to start our presentation today will be Fatima Taylor, who is our Program Manager in our Southern region. So I'm going to turn it over to Fatima.
Yeah, she's what? I knew that. Fatima.
Good afternoon, and thank you for the opportunity to present today. For our PowerPoint presentation today, we will take you through our overview of early intervention services. So
yes.
This is
It's
a
not Clark
collaborative
County
effort
doing it.
between Aging and Disability Services Division.
Fatima,
Early
my
intervention
apologies for
services.
interrupting you. We need to wait for the presentation
PowerPoint.
to pop up on the screen.
Okay,
So we can,
I'm sorry about that.
okay.
We have it in Northern Nevada. Can you see it in Grant Sawyer and
No.
online?
No, we cannot see it.
We do not see it
Oh,
down
we
here.
see it now.
All right. Will you let us
It's
know when
there.
it pops up for you?
It's there.
We now have a very small view of it, Chair. I'll follow along on my computer.
Okay, thank you. Yes, we have these resources both available online, and that there should be printed copies that you can grab in the room there with you. Please proceed when you are ready.
Okay, good afternoon. We will start over. I'm sorry that it's going to be so small, but if you can follow along, that is awesome. My name again, Fatima Taylor, Local Program Manager with Nevada Early Intervention Services. This presentation today is a collaboration with the IDA Part C Office and Aging and Disability Services Early Intervention Services. And presenting with me today is Dr. Lorianne Molina, the IDA Part C Coordinator, Sarah Horstman-Ploger, Health Program Manager with Nevada Early Intervention Services, and Ricky Robb, Deputy Administrator, Aging and Disability Services Division. For our agenda today, the presentation will include a general overview of the early intervention system, successes and challenges in meeting child health outcomes, and critical employee shortages. For the next slide, we'll start with the overview of the early intervention system. This is early intervention is an array of services and supports for infants and toddlers, from birth to 3 with disabilities or developmental delays. These services help their development and help them reach their full potential. When we look at these services, they're at no cost to families. Our funding sources are state general funds, IDA Part C funding, and insurance when families give us permission to bill. For our next slide, we'll talk about why early intervention is important. Early intervention is important because it has a lasting impact on a child's overall development, how they learn, and how they're able to regulate their emotions. We've already heard in previous presentations about the critical time of the first 3 years of life for brain development, and early intervention can really, when presented timely, can improve the quality of life for children. I will go ahead and pass it over to Dr. Lorianne Molina, and she will present the next set of slides. Thank you.
Lorianne Molina Lovell here for the record. I'm the Clinical Program Planner 1 and the Part C Coordinator for the Individuals with Disabilities Education Act, IDEA, Part C Office. As Fatima had presented, Our target population is from birth to 3 years with delays or disabilities. And here for you is further representativeness within our population. During December 2021, our federally required point in time count was 3,136 children. Of this population, a majority or 65% are male with 35% female. Our system does not yet have sexual orientation, gender identity, SOGI data, but we are planning to develop processes to provide this required data within our new data system, which is expected to be implemented during 2023. Further representativeness by race, ethnicity during 2021 is reflected here for you below for your reference. Our early intervention system is endeavoring to increase representativeness through a number of Child Find community outreach efforts.
And who's doing
And
Child Find? I
through
really want to
advising
know.
from our Early Intervention Equity Subcommittee. And next slide, please.
IDEA
Stakeholders
Part
within
C,
our early
regulatory
intervention
oversight,
system
supervision for
include the
comprehensive
following entities
EL
we wanted to
system,
share with you today.
formula grants, okay,
We
and
have the
special
governor
education. We know
appointed
all about that.
Interagency Coordinating Council.
Yes, but they don't have the
ICC,
data.
which is a federally required advisory
No
board
data.
for all states participating in IDEA Part C. The ICC is comprised of stakeholders across the field of early intervention, with subcommittees for child find, family participation, and for equity. Next, we have the IDEA Part C office, which is the lead agency providing general supervision and regulatory oversight of the comprehensive early intervention services system in Nevada. We receive formula grant funding and federal oversight from the United States Department of Education, Office of Special Education Programs, OSEP. We have offices in Carson City and Las Vegas. We're pleased to collaborate statewide with the Aging and Disability Services Division, which provides the day-to-day operations of early intervention services throughout Nevada. ADSD oversees and manages service delivery and service agreements. They are the system point of entry, SPO, for all referrals to the system. They also manage phase planning for services during the COVID-19 pandemic, and they manage the early intervention system budget made up of general funds, insurance billing, and IDEA. At this time, our presentation will continue with my esteemed colleague, Sarah Horstman-Pilger.
Thank you, Lorianne. This is Sarah Horstman-Pilger, Health Program Manager 3 of Nevada Early Intervention Services, Aging and Disability Services Division. As Fatima had mentioned before in slide 3, we have an array of early intervention services that we provide in the state, and some are listed for you here in this slide. And we do like to point out that services for children who are eligible are no cost to families and are provided in a child's natural environment. Down below, as Lorianne had mentioned, we have direct contact information for anyone to refer a child through our system's point of entry at those phone numbers listed below. Next slide, please. And as we've had our colleagues at Positively Kids present before us, we have outlined here for you the state regional offices, as well as our community partners and the regions that they serve. We want to let the committee know today that each program serves IDEA Part C required services. Additionally, the state regional offices exclusively serve children or the most medically fragile infants and toddlers, as well as some non-Part C related programs and services, such as our captive program, which was mentioned in a previous presentation, Child Abuse and Protection Treatment Act, as well as a screening and monitoring program that we have within the state that are for children who may have been released from the NICU without significant medical needs. Also potential fetal alcohol syndrome suspicions, in addition to also potential neonatal, sorry, gotta get my notes here, neonatal abstinence syndrome. So we have both of those services that the state holds, and at any time, if any of the children under our CAPTA or screening and monitoring program should show more significant concerns, family has the right to refer to Part C for full assessment and eligibility determination. I will now turn it back over to Lorianne Molina Lovell.
Here for the record once again. We're proud to share highlights of successes occurring in our early intervention services system. During COVID-19, our system ensured the continuity of services to families with the use of alternative service methods, such as telehealth services, allowed under OSIP and Medicaid. During federal fiscal year 2020, our EI system met our state systemic improvement plans, SIPs, target for children exiting early intervention services who had made progress in their social emotional development, with the target set at 68%. And the actual achievement reflected that 74% of children exiting statewide had made progress in their social emotional development and outcomes. This importantly ties into mental health for infants and toddlers. We attribute this success to the thoughtful, hard work from many among our early intervention and quality assurance programs, personnel, practitioners, families, and stakeholders promoting social-emotional pyramid model methods. Another highlight is regarding our American Rescue Plan funds, which are being allocated with consideration of data-driven needs and stakeholder input within our EI system, including a new data system, which was addressed by our colleagues from Positively Kids in their presentation immediately prior to this presentation. A system study to further identify system needs and solutions, and training and professional development for the retention and career growth of early intervention personnel. Next slide, please.
Early intervention for SNL, really?
Challenges experienced in our early intervention services system included that children under the age of 5 are not eligible for vaccination, and 50% of families surveyed during spring of 2021 responded that services via telehealth methods were challenging. And many families experienced challenges during the pertinent juncture of transition exit at age 3, which is the period of time when a child leaves our early intervention services system and when they may go on to receive services with their next program, such as an early childhood special education program or preschool. There towards the bottom of this slide is an excerpt of our Part C office's federal reporting to OSIP regarding families who found themselves waiting at the crossroads between early intervention and their next program, with delays and limitations that were attributable to the COVID-19
That's a lie. They were attributable to the lack of planning
Next slide, please.
and implementation here in Nevada. That's a lie.
OSIP does provide guidance to states for when services are impacted due to COVID, such as procedural safeguards and timely notifications to families. We will note that OSIP allows states to apply for additional flexibility to use IDEA Part D funds to serve children beyond age 3 under IDEA, specifically with an extended option. This option extends services to a child who previously received EI services until the beginning of the school year following the child's 3rd birthday, with parental consent and according to IDEA regulations. OSIP provides state incentive grants, SIG, to these states that elect to offer Part C services beyond age 3 under IDEA. At this time, early intervention is legislated for the birth to 3 years population.
Where's your data?
At this time in
Who
our
are you
presentation, we'll continue and conclude with ADSD Deputy Administrator Ricky Robb.
Thank you, Lorianne. Again, for the record, my name is Ricky Robb, Deputy Administrator for Aging and Disability Services, Children's Services. Based on the information shared by the community partners, the Nevada Early Intervention Community Partners Trade Association, known as the Trade Association going forward, and the state programs, it has been determined all early intervention programs are continuing to experience critical shortages in both direct and indirect staffing. As you've heard from our previous provider, it has definitely been an impact to early intervention services.
Action from
The shortages directly impact Nevada's youngest and most vulnerable population and their families needing specialty services. The impact to Nevada's early intervention system is the risk to this vulnerable population waiting for critical and timely services, with the goal to not negatively impact a child's development due to these challenges. It could result in a corrective action from OSEP. And it also could put us potentially with a wait list, which we have not seen in many years. So our goal is to a way to eliminate this critical shortage and be able to serve our populations appropriately. Due to the critical shortages for developmental specialists, what we call a DS, there have been multiple requests to modify the current requirements of the early intervention educational endorsement. We are currently working with the IDEA Part C office in the review of the potential options for licensure and retentions. Special population reserves critical services, my apologies, timely and by appropriately educated staff. The next slide, please. Slide 13. We're excited. So we will be ending on a really good note, which is something that we've been waiting for quite some time. The funds, the ARPA funds through OSEP actually afforded us to be able to work on two initiatives that we've been working towards for many years. A system analysis. We started with a analysis of our rate study. As you all remember from our last legislative session, we really did talk about rates and what did that look like for a comprehensive provider. The study has begun. We've got the initial data that was presented to the trade association as well as the comprehensive community providers last Friday. And so we're now in that phase of public comment. So they're working towards that public comment and that will close June 3rd. And then the HMA study, sorry, I just totally forgot to introduce who's doing that. So the Burns and Associates are actually the group through Health Management Associates who's conducting that study as a third party. We've been able to work with them to provide the information for the state providers as well as the comprehensive community providers. So far, we do have an initial draft of that study. And again, that was presented last Friday, May 13th. And we look forward to that public comment period to ensure we have all the information before that final analysis. The comments will be evaluated and then we'll be able to have that finalized and we hope to give that information to all of you in a future meeting. The analysis will also be reviewing the 50-50 requirement of the caseload split and the impact to services. It does impact service delivery when the system must enforce a rotation hold on parent choice. Parent choice is what's required by OSEP and as that federal law. It's also the right thing to do when we are allowing a family to choose which provider they would go to.
That's right.
In the past, we have found that when we're not at that 50-50 caseload split, that we have to artificially stop that parent choice and take a program out of rotation, which is typically those community providers, which is not in supportive of that parent choice model. And so it's really important for us today to share with you that that's an impact to the service and to the child and to the family if they're not able to have their choice of the community provider or the state provider they'd like to have their child receive services. So ensuring that we're within compliance with OSEP, we would like you to hear that request as we move
You're not
forward
in
and when we
compliance with
go into
OSEP.
the next legislative session.
You're right.
The great thing is we've learned many lessons already, and we're only at the beginning stages of the analysis. And through this, we've learned how different our state is. That Nevada is structured very differently from other states for
Yes,
early
it is.
interventions.
They're not doing early
services.
intervention.
One of those differences is how we are structured with the Part C IDEA office, Aging and Disability Services, our quality assurance, and the Nevada Early Intervention system as a whole. We're in different divisions. So there are times that that division actually separates us in the alignment of our funding, compliance, as well as our
It
service
certainly
delivery.
does.
So again, those are just items to keep in mind as we're moving forward with our analysis, as well as when we move into the next phase through the legislature.
Moving towards
The second
compliance.
initiative is another exciting initiative that many of you already know about that we've been working on. I've been with the program for almost 5 years. We've been working on it since I came in.
Bet you
So
have.
with the OSEP ARPA funding, we were able to work through the RFP process with purchasing.
Yeah.
And we are excited to say that we have secured a vendor and we're working towards the June BOE for that approval. So we're here.
Board
5
of
years later,
Examiners.
at least for me, it's probably been almost 10 for us, the need. You heard them talk about the challenges of an outdated system.
Oh, well.
Our hope is that we'll
Fraud
be able
is
to
real.
stop some of the triplicates that we have. Some programs have to put things in 3-4 times. Most are 2 at this point. So our track system will be eliminated, and then we will have a new system that is going to ensure that we have a comprehensive case management, billing, data, and federal reporting system that will be imperative for all of our programs to be successful, and that will help us to ensure that we are working for those children and being able to have them in all their information in one place. So no matter what program they're at, they're going to get the same system, the same processes, and the same supports that they deserve. So I thank you, committee, for taking the time with us. I know you guys have been here all day, so we really appreciate your time today, and we're open to any questions that you may have.
Yeah, because you're not doing any work. That's right.
Thank you so much. That is very exciting. I'm a huge fan of work smarter, not harder. And those
Me
single
too.
input systems make life so much easier on the back end for quality control, in addition to on the front end and putting in the data that needs to be utilized later. Are there questions for this presenter today? I believe Ms. Gorlow has a couple of questions. Please go ahead.
Thank you very much, Madam Chair. First I kind of want to share that early intervention means a lot to me, not only because I do, for transparency reasons, I work for Positively Kids, but my own son was referred to early intervention when he was about 2. And I'm really excited to hear that you guys don't have a wait list, because when he was referred, there was a wait list. And he
They don't have a
actually
wait list 'cause
aged
people don't know
out
how to get
before
the
he was able to
services.
get any services. And even today, as he's almost 16, I can still see some of his speech issues that sometimes I wonder, would they have been corrected if he had speech therapy early on? He's fine, but as a mom, you always kind of wonder those things. So that did make me think, when I was looking at the auto eligibility, I noticed that one of the criteria was a 27-week preterm. My son happened to be 36 weeks preterm. I had thought that at one point that was 32 weeks. So has that changed, or am I just remembering improperly? Because like I said, it's been 16 years.
Ricky Route, for the record, I'm actually going to pass this on to our program staff, and I'm going to pass this on to Fatima Taylor.
Yeah, to the Black woman.
Thank you for the question, Fatima Taylor, for the record. For auto eligible kids, about that long ago, and that's my memory, so excuse me if it's not that great, but for preemies, it was the 27 weekers. But for the 32 weeks, if there was still concerns and they didn't come out, they would have been auto eligible. What we could have done, informed clinical opinion to make the child eligible if there were concerns.
Thank you. And if I could ask another quick question, Chair?
Please go ahead.
Please go ahead. Okay, thank you. Since we're speaking of age, I really liked your graphic about the race demographics for those that are being referred to early intervention. But I was curious about at what age are children being referred to early intervention? Because as we know, the earlier the better, but my son didn't get referred to until he was 2. So do we have any sort of an age breakout on when these children are being referred? Thank you.
Ricky Rapp for the record. Thank you for that question. I would not say that we have that information with us today, but we'd be happy to get back to the committee.
Great, thank you very much. And that's all my questions.
Thank you for the questions. And thank you for the responses today and that follow-up. If you don't mind sending that to staff, we'll get it to everybody else. Great. I had one more question for you to kind of dive in a little deeper on the workforce issue. You mentioned a couple of things of wanting to explore retention and recruitment strategies, but do you have any ideas at this point or partners you're working with on establishing what those might be? We've got a lot of movement in the governor's office on addressing this particular issue across the healthcare spectrum, but I haven't heard from your particular providers about being kind of brought into those processes. So can you talk a little bit about what that looks like?
Thank you for the question. Ricky Robb for the record. Well, we're at a multi-level at this point. Some of them are state providers or developmental specialists. So obviously we have mastered levels, some doctorate levels, and then they are also required to have an educational endorsement, which is specific to Nevada Early Intervention Services. That is one piece that we are looking at because we get them and at about 2 years they're like, I can't make the 3-year cutoff. And so we are working with Lorianne and her team with Part C to determine what that looks like if there's modifications for that. So we're in the process of that review for developmental specialists. The other challenge is that many of them are contracted, and those are our speech and language therapist, our occupational therapist, as well as our physical therapist. With that group, they're all specialty therapists. Unfortunately, the state, as well as our community providers, are not able to compete based on what they're able to make either within a school district or the hospitals. And so that obviously would be a funding opportunity for us in regards to what that might look like. So there's many things obviously that we could look at with it comes to, we have found that therapies are not within the state range. They don't have a class spec. And so we would really look at what those ranges would be and how we might be able to meet that on a salary. So right now that's our specific when it comes to therapies. And then when it comes to developmental specialists, one of the challenges is that we require an additional, if they don't meet the criteria when they come in, there's an additional up to 3 years for them to meet that requirement. And I would put it out to my colleagues to say, if there's additional information that you guys would like to provide, please do so. Please raise your hand.
Please go ahead.
Thank you, Ricky, for sharing about those strategies for retention and recruitment. I would like to add that the IDEA Part C office offers flexible licensing options for developmental specialists that must meet their 3-year professional requirements. We provide an alternative licensure, or what we call an alternative certification, which is an equivalent of the Department of Ed endorsement in early childhood development delayed for ages birth through 7. And this alternative certification provides savings for developmental specialists on licensing fees. And although they are required to take the very same coursework as the Department of Ed requires, there is additional flexibility, especially if needed for extensions on that time frame when developmental specialists can show that they need extra time and that they have performed good faith efforts to meet their requirements. Some other strategies that we're utilizing in our system to promote retention include providing professional development hours at no cost to providers, and providers may use those hours toward licensure renewals with the Department of Education or with our IDA Part C office. And then I'd like to also add that we're also incorporating as many strategies as we can to address what is very prevalent in this field of public service regarding burnout and compassion fatigue. And so throughout our state, we're promoting self-care for our personnel, as well as diversity, equity, and inclusion efforts to support all personnel. Thank you.
Thank you. I had one more question related to the demographics breakout. I just flipped to that page one. Ms. Gorlow asked her question. And this number of, or the percentage of Black children who are recommended for intervention services. Can you talk a little bit about why that number may be so low? It just seems like particularly low population wise, but it particular like
according to the failure rate,
especially
it's
related
really
to
low.
our white and Black or
That's
white
right.
and Hispanic populations.
Not getting
Yeah,
any
if
services.
you have anything in regard to that.
Ricky Robb for the record. Thank you for the question. I will go ahead and ask that Lorianne if she has any information in regards to the question.
Because you don't, Director, you don't have any information.
Again, for the record, Chairman Peters is referring to the slide that depicts that 38% of children eligible for services are white, 37% Hispanic, and that low percentage of 9% for Black
9%.
children, as well as for those lower percentages that you would see for 2 or more races, Asian, Hawaiian Pacific Islander, Native American, and American.
She asked about the
Alaskan.
specific.
And I do not have that data with me at this time, Chairman Peters, but we can endeavor to locate that for you. Some of the information that has been brought to us is that these ethnicities and races are historically underrepresented. And so we are federally required by OSIP to increase that representativeness for those minorities in early intervention. Some of the efforts that we are endeavoring to complete to increase this representativeness includes engaging with our communities in various events, such as, and I can ask my ADSD colleagues to elaborate further on this because they are actually the ones involved right there at the direct level with the community and with families. But we do have those child find outreach efforts that we report on that are conducted throughout state and fairs, through parent council meetings. And then, as I had mentioned, we are endeavoring to address this through our Interagency Coordinating Council, ICC, Equity Subcommittee.
Thank you so much for the response. I would also be interested if you have any demographic breakdowns of your providers as well with regard to race. One of the things that we've heard over and over again is the lack of representation of minority healthcare workers, and particularly in the mental and behavioral health space. So I'd just be curious what those look like and how they compare to the representative demographics of those you serve. So thank you for that follow-up if you have it. Are there any other questions from the committee? I do not see any. Thank you so much for being here in your presentation. We really appreciate your time today. We look forward to seeing some of these ideas come to fruition in session. We're going to go ahead and move on to our next agenda item. This is our final presentation for the day. Agenda item 16 is an update on the coronavirus disease of 2019 health crisis interim study pursuant to Senate Bill 209 of the 2021 legislative session. Vice Chair Doñate will go ahead and give us a brief summary of his findings so far. Please proceed.
Thank you so much, Chair Peters, and good afternoon to my colleagues. For the record, I am Senator Fabian Doñate, representing Senate District 10. And today I'm presenting the second update on the COVID-19 health crisis interim study pursuant to Senate Bill 209, which was passed during the 2021 legislative session. Before we begin, of course, similar to last time, I would like to mention that there's a handout that is available on the committee's meeting page. And as stated before, Chair Peters appointed me to lead the SB 209 interim study efforts during the January 2022 HHS meeting. And as I summarized during our last meeting, I decided to hold various roundtable discussions with relevant stakeholders for each of the interim study requirements. And I will go ahead and try to provide as much updates to the committee meetings over the coming months. The last roundtable that we held was on April 25th, 2022. I invited several stakeholders to our second virtual roundtable discussion, and this one focused on the requirements related to the COVID-19 pandemic on businesses, their employees, the economy. Specifically, we looked at examining the benefits and challenges of implementing a task force between public and private representatives to support private businesses and the population areas of the state. And then we also tried to examine the economic impacts of the COVID-19 health crisis using an equitable perspective. As with the first roundtable, stakeholders received a survey with different questions, and we gave them the opportunity to give us policy proposals that we could look at for next session. A list of the stakeholders and who received the survey or who responded to it is provided in the handout. And most of it comprised of state, local associations, and nonprofit entities representing various business sectors and employees throughout Nevada. In terms of the policy recommendations, which is probably the most important part of this handout, on page 2 of the handout, there's a summary of the high-level discussion themes that has been provided, along with the strengths and challenges encountered throughout the pandemic. Some highlights for you. First, the greatest strength identified was the resilience of workers and the entities serving their communities. And second, the greatest challenge identified is the critical labor shortage, which participants said is being impacted by both inflation and the high cost of childcare, transportation to work, and housing. Additionally, policy recommendations were also summarized on page 2. One recommendation highlighted the need to update the state's process for moving federal funds directly to those in need. And I want to note that this was already brought up during the first roundtable discussion. And of course, while there were consistent themes identified during the roundtable discussion, we received many different policy recommendations from survey respondents. Therefore, we decided to go ahead and outline those specific recommendations provided in the addendum, which you can find on page 3 and 4 of the handout. Chair Peters, I look forward to sharing the final updates of the study. Our next meeting or our next roundtable is going to be on the discussion of our public health workforce. And then the final roundtable is going to be discussing health equity and special populations. So again, for you, Chair Peters, and any of the committee members, this concludes my remarks, and I'm available to answer any questions that you may have.
Thank you so much, Vice Chair Doniate. Really appreciate your effort and work in this space. And I know from folks that have an interest in this area, we really appreciate the inclusion and discussions that are quite specific and pertinent to the issues at hand. So thank you so much for your effort. Are there any questions from the committee related to this update today? Not seeing any. Thank you so much again. This report is great. I'm going to bring it up with the one from, I think it was our last meeting. Look at the two together and look forward to your final report in the coming months. Okay, we'll go ahead and close that agenda item today and move on to our final agenda item, public comment. We will start public comment with those in the physical locations and then move to public comment from anyone who has called in. There is no one in the room up here in Carson City. No one coming in as I'm speaking. So we're going to go ahead and see if anybody in Las Vegas would like to come to the podium for public comment. I'm not seeing anybody coming up in Las Vegas either. Staff in our broadcast and production services, please add the first caller to our public comment in the meeting. We may need to give this a couple of minutes because I know there is a lag. So I will ask for BPS to update me on public comment line in about 1 minute. All right, BPS, is there anybody on the public comment line at this time?
Yes, Chair, we do have one caller. Please stand by.
Thank you so much.
Hi,
Caller,
good
you're
afternoon,
unmuted and
Chair
you begin.
Peters. Oh, sorry. Thank you. Good afternoon, Chair Peters, members of the committee. For the record, my name is Katie Ryan, and I am Assistant Director of Government Relations for Dignity Health St. Rose Dominican. Today, you have heard from some of my colleagues about the need for additional Medicaid reimbursement for community health workers and peers when it comes to items like substance abuse, mental health, and violence prevention. Myself, Dr. Deborah Cool from UMC and the UNLV School of Medicine, along with a national group, the Health Alliance for Violence Intervention, would love to present additional information to this committee around other states that have done this work and allowed for additional reimbursement for providers for violence prevention. Our providers, particularly in our emergency departments and trauma centers, see these violence victims. 2/3 of victims of gun violence are Medicaid patients, and roughly 1/3 of them will be injured again without intervention. Hospital-based violence intervention programs consistently decrease the risk of being re-injured, generally from that 1/3 down to about only 4 or 5%, while increasing access to needed services such as primary care and mental health. Intimate partner violence is also a huge issue. 1 in 4 women have dealt with this issue, and consequences can range from physical injuries, chronic health conditions, mental health disorders, and even death. 1 in 5 homicide victims are killed by an intimate partner. We have been in discussion with Medicaid and others at DHHS, and there is an appetite to move forward, but we would also love the opportunity to present to this committee and also get your support and funding for this health equity issue. Thank you, and I'm available for any questions you may have.
Thank you so much. Together, I will, because of travel, I will be attending in Las Vegas at Grant Sawyer, barring any public health crisis circumstances and lack of travel. But at this point, I will assume to be down there. So I hope to see my colleagues in the building if you're able to make it. And with that, our meeting is adjourned.
Thank you, Chair.
The process within a 7-day time frame. Even though they knew that an eviction notice was going to come, they did not recognize it when it did and didn't know what to do after it arrived. This process leaves tenants scrambling to find new housing in an unreasonable short amount of time. Many individuals go into emergency shelters or weekly rentals as an immediate and transitional solution, only to be trapped there and unable to find any permanent solution in the future. This process places tenants at risk of losing their job. As they figure out what their next step may be, they go into crisis mode. This process leads to transiency for many families, affecting the access of health and social services, negatively affecting student outcomes, and increasing the risk to homelessness. This process minimizes the true level of problem since many people self-evict. So there's no accurate data on the real magnitude of evictions, as we've already heard today. Some evictions aren't being counted in the data unless tenants respond to that notice. And thus we can assume that as extreme as our eviction data is, the reality is much worse. So what does the data say right now? We've heard about some of these numbers, but data from the Gwynn Center between 2000 and 2016 indicates that Nevada's eviction rates are higher than the national average, second highest after Arizona and the Intermountain West. Some census tracts in Clark County alone are over 2 of them are over 5%. And the listed rates are undoubtedly low since so many evictions are not even counted.
Ray mentioned that one of the concerns is the potential loss of employment. A common view is that losing your job leads to losing your home. But evidence suggests that in many cases, people lose their home first. And then because of the instability created by no longer having a home, often the time they've had to spend during 7 days missing work or whatever, trying to cope with the situation, they end up without a job. So it's just the opposite of what we often think about. We also know from one study that the likelihood of job loss is estimated to be 11 to 22% higher for individuals who have been forced out of their homes, such as with eviction, compared to those who have not. And one study indicated that renters who are evicted tend to move to poorer, higher crime neighborhoods compared to individuals who move for other reasons. Time is limited to find a new home. If you're struggling to stay in the home that you're in, how much time do you have to devote to finding a new place to move to, particularly in the current housing market that we see in Clark County? And with an eviction on record, housing options become more and more limited. But the cost doesn't necessarily go down. Many people end up living in a weekly rental, an option with limited space or stability, but very high costs for what it actually provides. People who end up in that situation are caught in a cycle. They are using all their resources just to stay there week by week. They cannot save to get out of that situation and into any type of long-term rental. They're caught in the cycle. An eviction can initiate this cycle of housing insecurity and transiency. We heard one story from a woman who, with her husband, was fostering 6 children. They qualified for Section 8 housing, but the long waiting list limited this option for them. They were then evicted from their home during the pandemic because the husband was temporarily unemployed. They are now coping with 8 people living in a 1-bedroom budget suite while they struggle to regain financial stability. And I worry that they're never going to get out of that weekly because of the situation they're in. This transiency and living in limbo can impact access to needed services, create transportation issues, and lead to generational impacts when children's education and learning outcomes are affected. The negative impacts of being forced from one's home can become long-term. The cost to our community also goes up because the need for public services increases in both scale and for a much longer period of time when you have people constantly living in very temporary housing. And to just briefly mention a little bit about the impact on education, studies across the country on student outcomes in a variety of metropolitan areas show that student learning outcomes, such as lower math and English proficiency, loss of math and reading growth, lower assessment scores, plus new behavior problems and increased risk of dropping out of school, are closely tied to attendance, which is negatively linked to housing transiency. The more transient the family is, the greater the absentee is in school and negative outcomes. A review of Nevada data by the Gwynn Center supports those findings. Their analysis suggests a positive association between transiency rates, eviction rates, and school or low school ratings in Clark County. Specifically, schools with a higher than average transiency rate are located in neighborhoods where the average eviction rate significantly exceeds the state and county averages. Eviction is a problem in Nevada, affecting the well-being of all our residents. We are, in effect, creating a permanent underclass with little chance to escape an ongoing cycle of economic insecurity. The current system just does not work and must change.
Everyone deserves to be heard. Tenants should not be made to initiate court proceedings. They should be guaranteed. And a judge should hear evictions so that tenants has his or her opportunity to be heard and possibly connected with resources when they're there. We need to increase the time for tenants to transition and find new housing to lessen the stress and adverse effects of moving. As in all of the stories that we've heard, the short notice of summary eviction forces families to make drastic decisions about their housing security. The long-term consequences of the transitional step between one long-term rental and another traps our community in an impossible cycle. We need a fair process for both tenants and landlords. Ideally, no one should be in eviction court. Evictions are destabilizing, and we need a social safety net that supports our community from its first sign of challenge. The reality is that today, not enough of our tenants even have access to this process, have the means to engage with this process, or have the knowledge to navigate this process. As Nevadans, we stand together across a diversity of communities in recognition that much work lies ahead. We have built and continue to build a broad constituency across the state that understands the inequities that COVID-19 has further brought to light, as well as the long road required to strengthen our economy for the long term. Building a more just eviction process through the court is an essential part of this work. And we are committed to the work ahead and want to work with state leadership for a more just economy for all. Thank you.
Thank you. Thank you so very much. We appreciate you staying all day. The information that you have shared with us is critical, and we're grateful. I'd like to go now to those on Zoom. If you have any questions for our representatives from Nevada for the common good. Very good. Chairwoman Scheibel, would you please let me know if there are any questions or comments? Questions really from the folks up north?
There are not, thank you.
Thank you very much. Any questions or comments from those on the panel here in Southern Nevada? Thank you very much. We really appreciate you being here. At this time, I think that wraps us up for this portion of the agenda. I'd like to turn this hearing back over to Chairwoman Scheibel. Thank you so much for allowing me to step in here, and gavel is now yours. Thank you.
Well, thank you, Assemblymember Summers Armstrong. You did an excellent job, and it was nice to be relieved for a little while there. And thank you for walking us through those important and interesting presentations. That brings us to almost the end of our agenda. As you guys know, if you stay until the end, you get a special prize, which is the inside scoop on the request for proposals that's going to be posted on the Judiciary Committee website probably on Monday. It just kind of explains an outline for how to submit a proposal for a bill draft request if you'd like one to be considered at the August meeting. Accept them from anyone and everyone. There's not a form to fill out. You just have to put your request into a Word document or an email and send it to the committee. Doesn't guarantee that we'll hear it, but it does guarantee that we will review it, and then we can reach out to you and from there figure out what to do, what to hear at our August meeting during our work session. So I encourage you all to take a look at that, send in your requests, and that brings us to the last item on our agenda before we adjourn, which is the second public comment period. We will start with public comment here in Carson City. Anybody wishing to give public comment will have 3 minutes each. I already see we have some people coming down to the front. And whoever wants to go first, just go ahead whenever you're ready.
Thank you, Chair Scheibel. This is Nick Shepak with the Fines and Fees Justice Center. I'll be very brief. I just have to make a quick correction to something I had said on the record. I was asked earlier if the court system in Colorado was unified. And while it's a small discrepancy, it is actually integrated. Unified suggests, like in California and in Kentucky, that it is a Supreme Court down. In Colorado, the state courts have an administrative body, and then what would be justice courts are called county courts there, and their municipal courts have their own administrative body. They're unified underneath that particular body. The question was about data collection. So yes, they use the same systems. All that data is reported. It doesn't really change that, but it is not a true unified system. It is an integrated system. I just wanted to correct that.
Spoken like a true lawyer.
Good afternoon. My name is Jennifer Richards. I hold the office of the Attorney for the Rights of Older Persons and Persons with a Physical Disability, Intellectual Disability, or Related Condition. We shorten that to Rights Attorney. I'm appointed by and serve at the pleasure of the Governor. I'm housed within the Department of Health and Human Services. Our motto is helping people it's possible. I wanted to come today to give a voice to the over 250,000 older adults in our state and the thousands of persons with disabilities living in our state that are disproportionately impacted by evictions and homelessness. I'm happy to provide I'm happy to provide the committee some additional data points following today's presentations. In Nevada, we do have an elders count. The latest elders count was in 2021. That provides authoritative data on Nevada's older adults. It's a collaborative effort between the Center for Healthy Aging, the Office of Statewide Initiatives at the University of Nevada, Reno, and the Aging Disability Services Division. That report identifies that the number of older adults on the verge of homelessness and entering homelessness has increased. So we can see from 2018 to 2021, we had higher numbers on the verge of homelessness. Now they're homeless, right? And that reflects national data that I can also help provide the committee from the Justice and Aging and the National Low Income Housing Coalition. I did want to touch on 2 points from some of the topics today. One discussion was social services. And at our division, we have a slogan called "No Wrong Door." And that means whatever door you enter, it's not wrong, you're going to get connected to services. And I think Judge Zaragoza's presentation really emphasized that the courthouse needs to be a door that is not a wrong door to enter to get those services. But sometimes that's not just initiating services. Because of the eviction process in our state with the tenant as the first filer, they may already be involved with social services and social services doesn't know. I know at our agency, we've had social workers in our community-based care team or in adult protective services have clients evicted because they don't know, they're not able to provide those social services supports to help keep them housed. It could be a non-payment issue. It could be an abuse, neglect, exploitation issue. It could be needing supports in the home so that they can maintain the habitability of the home and stay housed, whether that's a personal care assistant, getting on a waiver service, or any of our other services that we also subgrant to community partners. I also wanted to let the committee know that I serve as the state legal assistance developer for Nevada and oversee our legal services grants under the Older Americans Act. We have deployed additional funding, including the additional federal dollars to support our legal services providers who are completely overwhelmed in responding to evictions. We're piloting a $500,000 neighborhood legal access program to meet people where they are in the community and partner with our public libraries. At our division, we had a total of 77,000 contacts from July 1 to March 30th, 2022 through our Nevada 211 asking for housing and shelter assistance. So if you look at the numbers, that's a huge amount contacting the Aging and Disability Network to receive assistance. So I think part of the problem is helping people to plug into the existing framework. And the process right now is difficult for persons with disabilities or older adults because it's not necessarily accessible. What if someone's blind? How are they going to read the notice posted on their door? At least if they go to the courthouse, there's ADA accessibility and someone can help walk them through what's going on. So I know it's 5 o'clock and I'll conclude there, but please feel free to reach out to me if I can be a resource to this committee.
Thank you so much. And we would definitely like to hear some more about the aging and disabled community. So I think we will touch base with you before our next meeting. I don't see anybody else in Carson City, wherever I am, to give public comment. Is there anybody in person in Las Vegas?
There is not, Chair.
All right, then we will go to the phones. As I mentioned last time, I learned that we're on a little bit of a delay with some of the streaming options. So I am going to sit here for about 2 to 5 minutes to make sure that we don't have anybody on the phone line if there's not anybody there already. BPS?
Thank you, Chair. If you wish to provide public comment, please press *9 now to take your place in the queue.
Good afternoon, Chair Scheibel and members of the committee. This is Kendra Bertschy, BERTSCHY, with the Washoe County Public Defender's Office. I want to thank the committee for again touching issues of bail, which is extremely important. We want to thank this committee for their hard work that they've done so far during this interim, but also during the legislative session to enact bail reform. We did notice at the very
Okay, I'm about to stop. I didn't realize that it ran over into another meeting. But y'all just need to understand, we all have a personal responsibility to ensure access happens for the youngest and the neediest